Mm, 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 mm.
Hello, everyone. I, Dr. V.C. Manoj, on behalf of National Neonatology Forum India and Learn from the Legends, thank you all for joining us today. Hearty welcome to this last session of this year, 2023, the fourth year of Learn from the Legends International Neonatology webinar series. We have today a very interesting discussion on one of the most mysterious vital parameter of a neonate, blood pressure. And we have a legend in this field who has published a very interesting paper recently on blood pressure trends and phenotypes in neonates. to deliver today's lecture. Professor Yased Elsayed from University of Manitoba, Canada. Hearty welcome, Dr. Yased. And the moderators for today are two very good friends of mine, Dr. Mamta Jaju, Professor of Pediatrics from Delhi, India, and Brigadier Dr. Karthik Ram Mohan, Consultant Neonatologist from Indian Army. Welcome, both of you.
Thank you.
Now, friends, before I hand over the platform to our moderators, here are a few housekeeping announcements. The chat box on your screen is primarily meant for housekeeping announcements and greeting each other. Kindly type your questions for discussion at the end of this lecture in the Q&A box and not here in the chat box. And our next session after today will be in the new year 2024. So this is the last session of this year. The first session for the next year will be on 1st of February 2024 on a very common topic which we have discussed so many times, but we are looking at the recent concepts, BPD. What's new in early postnatal care to prevention of BPD by Professor Huang Shang, University of Pennsylvania, USA. So please continue to join us next year as well. Thank you so much. Now over to you, Dr. Mamta and Dr. Karthik, to introduce the speaker and initiate the session today.
Thank you so much, Dr. Manoj. Good evening, everyone. So today, as Dr. Manoj said, we are going to have a talk on very interesting topic. So we know that when we are treating with the sick neonates, how important it is to take blood pressure. But we are always in dilemma that what to do with the blood pressure norms because of the many other things not available with us. So with a very interesting topic that what is normal blood pressure in neonate, recent insights into BP trends and phenotypes, I request our other moderator to please introduce today's speaker, Professor Yased. Thank you.
Thank you, madam. Good evening, everybody. I'm privileged to speak about the speaker. Today's speaker is Dr. Yased Elsayed. He is an associate professor of pediatrics at the University of Manitoba, where he is a staff neonatologist, a registered echocardiologist, and researcher at the Children's Hospital Research Institute of Manitoba. He is an academic fellow of the Royal College of Physicians of Canada. He has a very long CV. He founded and directed the integrated hemodynamics program and point-of-care ultrasound there. He has conducted more than 100 workshops in the last 7 years at various forums. His research papers are in the field of hemodynamics, point-of-care ultrasound, and physiology-oriented practice, in which he has published more than 100 articles in various journals, books, and abstracts. He is editor of multiple international journals and has authored 10 institutional Canadian Pediatric Society and American Academy of Pediatrics guidelines. He has founded the first internationally recognized websites, pocuneo.org and neopeds.academy, dedicated to virtual education in medicine and physiologic-based practice, which website has over 8,000 members. He is the designer and director of Manitoba's neonatal educational curriculum of the Learning Management Digital System, LMS. Importantly, he is the founder of the lung ultrasound program and has actually replaced chest X-ray for diagnosing lung diseases and founded the first training program for respiratory therapists to perform lung ultrasound. He founded the intelligent monitoring in NICU by near-infrared spectroscopy and has trained staff in the clinical applications. He has founded the clinical decision support artificial intelligence to help decision-making and design many clinical calculators. Dr. Yased is a recipient of the 2023 Emerging Lead in Neonatology Award from the Canadian Pediatric Society, as well as a 2023 Ronald Duhamel Innovation Award. And his most recent award is Emerging Academic Leader Award from Pediatric Chairs of Canada. We eagerly look forward to your talk. Thank you.
Wonderful. Thank you very much for this kind introduction. And thank you again for the invitation. It's a great honor to me to present in this wonderful, great platform. And good morning, good afternoon, good evening, everyone, wherever you are, all over the world. Just for the sake of time, let me share the screen and start the presentation. So today, as the wonderful colleagues, moderators mentioned about the importance of blood pressure as one of the most important vital sign that we use every day for stable and also for sick neonates. So the topic today, what is the normal blood pressure in neonates? And I will be talking about the trends and phenotype. So now we are going far beyond the simple definition that we have used for a very long time, blood pressure equal to gestational age. We are not using that for 10 years. So if you are still using this definition, I hope after this presentation, we'll stop using this simple one because it's non-physiologic and also not evidence-based. I hope everyone can see the first slide.
Yes, we can see the slide, Doctor.
Okay, wonderful. So I have nothing to disclose in this presentation, and I have four main objectives today, or four main answers of four important questions. First question to be answered, what is the physiologic value of the blood pressure? So just to go back to the very basic question. Then what are the phenotypes of blood pressure trends? So we'll come to know the blood pressure trends, and if the blood pressure trends outside the normative values, then we should consider to treat. And after that, I will just go over quickly what medication we should select to treat. Then what are the normative values of blood pressure during postnatal transition, which is very critical period because during that period, the IVH develops. And that might develop because of fluctuation of the blood pressure. And then the last question, what is the physiologic definition of hypotensive shock based on the normative value? So what is the dilemma of the blood pressure? Why it is really a big issue for all of the neonatologists? It's still question not yet clearly answered to a lot of our colleagues. A lot of studies, and I'll just take an example, a lot of studies done to define the blood pressure threshold to treat. So what are the threshold to consider shock and treat? One of them, this very interesting study done in US, 16 centers participated in this study, and they try to compare between 15 definitions of low blood pressure. So they tried first to define the low blood pressure or hypotensive shock. And in the study, the question was not answered. Antihypotensive therapy administration was not associated with improved in hospital outcomes for any of the 15 definitions of low blood pressure investigated. Alternative methods. So now we are asking, we should look for alternative method, deciding who to treat. We need to also avoid or minimize harm of using this medication. So the conclusion from this study for the 15 definitions of low blood pressure investigated, interestingly, the therapy as antihypotensive therapy was only prescribed to 3 to 50%, very wide range among the 16 centers. 3 to 50% of infants with low blood pressure. And paradoxically, the antihypotensive therapy administered to almost 30 to 40% of infants without the blood pressure as per the predefined criteria they selected. So what's the problem now? Why they did not find, and there's not only this study, a lot of other studies. So the problem is they tried to define the hypotension or low blood pressure without even defining what's the normal blood pressure. That was really very interesting. So they did not pay too much attention to define the normative value, which is really difficult. And I will let you know why. We stayed almost 5-6 years to try to define the normative value in premature infant. But I have to clarify first, we should not consider hypotension as a disease. It is not a disease. It is a marker of compromised blood flow. And it is bare autoregulation might be compensated or might be not. So hypotension might happen with many physiologic phenotypes. There's not just one number or one criteria, which is simplified in a lot of centers as blood pressure normalized as equal to gestational age or corrected gestational age. And the blood flow critically decreases when the blood pressure trends below the autoregulation threshold. So you may have blood pressure fluctuate within the autoregulation, and that should be considered as normal. We should not intervene with that. So what is the physiologic value of the blood pressure? So we need to understand the physiology of the blood pressure. And if you ask me what's the blood pressure, I will maybe define it as simply, it is bumping a volume against resistance, making a pressure gradient moving the blood forward. So that's the value of the blood pressure. The blood pressure is a gradient. So it is higher at the heart, higher than the aorta, and then the aorta higher than the arterioles, higher than the venules, and then back to the heart. So this pressure gradient propagates the blood from the heart back to the heart again in the circulation. So we have now, it is bumping of volume against resistance. And just to go back to the physiology of the fetal circulation, there is two types of resistance that we need to understand. In the right heart, the heart is facing the resistance of the pulmonary circulation, which is very high in the fetal circulation. So in the fetus, we have the right ventricle facing high pressure. So resistance is high in the right side of the heart, and that should be decreased after birth when the lung is inflated, and the pressure should be decreased now to the minimum pressure. It is opposite to the left heart. Left heart is facing very low pressure with the placental circulation because the placenta is the lung for the fetus, the organ of exchange. So in our body, we should have one circulation with high resistance. That's before birth is the high right side. And after birth, we have another circulation with high resistance, which is a systemic circulation. So after birth, now the lung is functioning, and the lung should be at very low resistance, and systemic should be high resistance. That might not really happen in a lot of babies simply. So if the resistance stayed high, or for the pulmonary side, or did not increase enough in the systemic side, then we may have issues with the circulation. So that now understand that the mean blood pressure is proportional to, not actually equal, flow and resistance. So based on the ratio between both, we understand the blood pressure variables. So for example, when you have significant decrease in resistance and slight increase in the flow, like the body might try to compensate, we may have the most common type of shock in our population, which is the vasodilatory shock or physiology. When you have loss of resistance or vasoplegia of the arterioles, and you have the opposite, increased resistance and followed by significant decrease in high myocardial performance because the heart may not be able to contract against increased resistance. Then we have the vasoconstrictor physiology, which is less common, but we may have the disaster at the end, very low systemic vascular resistance and very low blood flow, and is related or advanced or cardiogenic advanced shock. We'll come to that later in more details, but now we need to know what are the blood pressure reference values. Now we need to answer this question, the normal values. Before we define or to know the hypotensive shock and when to treat hypotension, we need to know what's the normal. So we did the systematic review among our group here. So I was assigned to do the normative value for the Canadian Neonatal Network. So to have one blood pressure normative value among the Canadian centers. And we did extensive review. And as you can see here, unfortunately, we could not find any study to define normal blood pressure accurately based on the invasive versus non-invasive blood pressure measurement. But we found, interestingly, Zobro, which is the best designed article, although it was published 1996, but the design was perfect. And I will tell you what's the limitation of that. And also, we found a study which is really reasonable reference for term infant. So Zobro is mainly for preterm infant, and Allison Kent for term infant. And we added some modification to Zobro based on our data, and we use normative values for so many years. Although we have to mention that the normative value based on non-invasive blood pressure values, they evaluated which is strength of the study, the blood pressure for 90 days for all of the premature infants, and they dedicated only 2 investigators, 2 nurse practitioners. We're working every day to measure the blood pressure twice with the same technique. So that was a very strong study, but again, the limitation, they used only non-invasive method from the beginning. Although we are using, as you know, for sick infants for the first 3-4 days of transition up to 1 week, sometimes invasive arterial blood pressure. So we use the study to develop normative values with some modifications, and we included here the pulse pressure. So we have the systolic, diastolic mean, and the pulse pressure. We extracted that and we modified based on our data, and we used that for many years, but that was not enough. So we did another study, and there's the Allison Kent study for term infant. So also we used the study for term, the infant who born as term for the first 4 days of life. And back to the dilemma of the blood pressure, now we understand that or when you ask this question, do we as neonatologists understand the blood pressure physiology and limitations? I will go over that because that's very important in more details. Do we have globally acceptable normative blood pressure values in preterm during different stages of postnatal maturation? So the first 3 days of life, and based on invasive blood pressure values that we are usually using in very premature infants less than 28 weeks, and we need to know the limits then, which might be a trigger when the blood pressure fluctuates to induce IVH. So what is the physiology of normal blood pressure? So let us answer this question clearly. So the blood pressure is diastolic blood pressure. That's the basic blood pressure or the baseline blood pressure. So diastolic blood pressure reflects 2 things: systemic vascular resistance and the blood volume. So it is the pressure inside the container and the content of inside the container, the blood and the resistance created by the arterioles, mainly arterioles. The heart pump on top of this basic pressure to create pulse pressure, not systolic pressure, which is misunderstood part among a lot of neonatologists. They may consider systolic blood pressure reflects the systolic performance of the heart. No, it is a pulse pressure, which is equal to heart performance and pump action. And then pulse pressure plus diastolic equal to systolic pressure. So systolic pressure is dependent variables dependent on pulse and diastolic. And also mean blood pressure is 2/3 diastolic, 1/3 systolic. So it is also dependent variables. So now we have 2 independent variables, the diastolic blood pressure and pulse pressure. So it makes sense when you look at the blood pressure, pay attention to diastolic pressure and pulse pressure more than other parameters. So what are the phenotypes based on that? So quickly, I will explain like 3 main phenotypes. We have other phenotypes, but for the time, I'll just go over the 3 main phenotypes. Vasodilatory, when you have low diastolic blood pressure, and pulse pressure will stay normal. In vasodilatory shock, the pulse pressure may be normal and even may be wide pulse pressure in some situations. Systolic pressure will decrease because it is a sum of both, and then stroke volume might increase. As for compensation, heart rate will increase, and cardiac output might be a little bit high. In vasodilatory shock, we'll see the heart might be hyperdynamic in this situation, as you can see here, but the calculated systemic vascular resistance expected to be low. And as you can see here, the trend is a trend of the arterial blood pressure monitoring. The trend is decreasing over time. and with maintained pulse pressure. That's very important. So the red area here, which is maintained all over while the blood pressure is dropping, is the pulse pressure. So we have normal blood pulse pressure maintained. And just after we started the vasopressor, you can see the trend is increasing. And this is very common in septic shock, systemic inflammation, late onset shock, medications like vasodilators, morphine, and with acidosis. The other type, which is vasoconstrictor, in this type, we have the diastolic blood pressure might increase, or at least to normal, and the heart might not contract well, and you'll see narrow pulse pressure, and because of narrow pulse pressure, you see low systolic pressure, low stroke volume, heart rate will increase, but cardiac output is low, and high calculated systemic vascular resistance, normally between 150 to 250 millimeter mercury per liter per kg per minute. So there's a normal value for systemic vascular resistance, and you can calculate it at the bedside if you have the mean blood pressure and the cardiac output. The heart, as you can see here, globally is very weak, not contracting well. And you see here, the pulse pressure is narrow. And if you look at the mean blood pressure here, it is normal, or even above the low, like the median or the mean value, or you may see it even increased. The only thing detected here is a narrow pulse pressure, very narrow pulse pressure. So if you look at the mean blood pressure here, you will not detect what's going on. You will see only the infant deteriorated with lactic acidosis. So this is typically almost equivalent to systemic hypertension in adult. And after start of milrinone or dobutamine, you see the pulse pressure widen with normalized blood pressure and normalized hemodynamics. It can be commonly seen in failure of postnatal transition adaptation in premature infant when the systemic vascular resistance increases after birth. The heart might not contract well against resistance. It might work well in term infant, but some preterm infant might not tolerate a sudden increase in resistance during shift of fetal to postnatal circulation. Post-PD ligation syndrome, although we are not doing surgical ligation anymore for so many years, or post-AV malformation embolization, or in pulmonary hypertension. In some infants with HIE, because of cooling, might increase the vascular resistance and might induce vasoconstrictor physiology. And on top of that, you may have the heart performance is impaired in HIE. In some situations, septic shock, although it is rare in neonates, is more common in pediatric age group to see septic shock with vasoconstrictor physiology. And the last type is very easy because you have everything low. Everything is bad, and because it is really late. And I hope that you will not wait until you have this such late stage when the heart is very poorly contracting and failing, because now the heart cannot contract against even normal resistance. And you see everything is low. Systolic, diastolic, narrow pulse pressure. So it is failing circulation now. And you need to use a strong medication like epinephrine to support both the heart performance and the resistance. It is common in late situation. In low preload, if you are giving dobutamine or dopamine on top of low preload, you may get worsening of shock, failure postnatal adaptation late, pulmonary hypertension, also myocardial dysfunction. Mechanical ventilation with high mean air pressure because of low venous return in this situation, progressive severe acidosis. Keep in mind, if the pH less than 7.2, then the catecholamines sensitivity expected to be low. So the body will not really respond to either circulated catecholamines or catecholamines as given medication. Or overdose of any troops. That's very common. If you give dopamine, dobutamine, and epinephrine on top of that, very high dose, you will get the same effect, cardiogenic shock with failing heart. So that's kind of iatrogenic. If you don't have invasive blood pressure, it's okay, no problem. You can use a non-invasive pressure, but very frequent. If the infant's unstable, you have to apply the cuff and then adjust the monitor to measure the non-invasive pressure every 10 to 15 minutes and get the trend over time. So just to draw a line between all of these interrupted measurement, and you can get an idea about the trend. As you can see here, the trend is decreasing in this infant who is behaving with the vasodilatory shock. You can use, if you have the histograms in your blood pressure monitor, and the histogram will give you very nice idea about the 24 hours trend of the blood pressure, especially if you are planning to wean the medication. You can adjust the time. You can make it 4 hours. You can make it 8 hours. Any time from 1 hour to 24 hours, you can detect over the blood pressure trend for diastolic and for systolic blood pressure, and also for mean blood pressure. And you can understand how much time this infant spent below the 5th centile. So this infant here, the 5th centile for diastolic with 35 millimeter mercury. So you understand that 18% of the time, which is kind of significant time, this infant is not really ready for weaning yet, because you have still 18% of the time below the 5th centile, and also 14% of the time below the 5th centile for systolic, which is 50 millimeter mercury. So I have now conclusion number 1 in this presentation. Regardless of the normative table that you are using, the trend is very important. So don't worry about whatever table or whatever normative values. The most important to look at the trend over time. And you have more than 20% change of the trend from the baseline to below the baseline by 20% or for more than 30 minutes. Don't keep watching that. This seriously, you have to take action. So it is important to know the blood pressure trends in preterm infant during transition. It is really important. During transition is a critical period that IVH might happen. So very early during the first 6 hours to 24, 36 hours, we may have the blood pressure is low, which is really hypotensive stage, autoregulation is poor, and we may not have IVH developed yet. But once the blood pressure normalized and increased, we may see this IVH happened around 2nd or 3rd day of life when the autoregulation improved. So it is a reperfusion stage when the blood pressure shooting up or increased. Not only the blood pressure, it also detected, or more important to happen, was sudden increase in the CO2, carbon dioxide. So we have the blood pressure autoregulation curve here. So the y-axis here is the cerebral blood flow, which is not linearly following the blood pressure. So here you have the cerebral CO2, or you have the blood pressure values, which within this area here with the fluctuation will be the cerebral blood flow expected to be maintained. So if you have hypocarbia or hypercarbia within the autoregulation threshold, we are okay. Also hypotension or hypertension. But once the blood pressure decreased below the autoregulation threshold, you will see significant drop of the cerebral blood flow, and the opposite. When the blood pressure increases above the autoregulation threshold, you will see significant increase in cerebral blood flow. Here, the IVH happened. So the other problem, autoregulation is not expected to be effective and mature in premature babies. So it's almost linear, especially during the postnatal transition. It takes about 2 to 3 days to be a little bit more mature. And then it takes about 6 months to reach the term value, which is close to 1 year. At 1 year is almost adult value. So the autoregulation is not really one type of autoregulation for everyone. It might be affected by a lot of things, especially the prematurity during postnatal transition. Now we'll come to this question. What is the impact of blood pressure and the carbon dioxide on cerebral blood flow? We did this study, which not yet published. It is under review, but I'm showing the most important slide, which is very interesting finding related to the relationship between IVH and the changes in the blood pressure and carbon dioxide. So we have here the mean blood pressure in purple color, and you have the carbon dioxide measured in either by transcutaneous monitoring or by frequent blood gases every 6 hours. And then you have the mean blood pressure. Sorry, we have the cerebral oxygen saturation by near-field spectroscopy, which reflects cerebral blood flow, and you have the hemoglobin here. So you can see here where the blood pressure was okay, kind of low, but increased. And also, you have also in some patients, the CO2 increased, and that was associated with sudden increase in the cerebral blood flow. And that was detected in the blood gases, a sudden drop of hemoglobin here. So the hemoglobin was used as a marker that we have to screen followed by short period, maximum second day of life, or second day after drop of hemoglobin by cranial ultrasound. So cranial ultrasound confirmed IVH, but we detected or assumed the time that IVH developed by the drop of hemoglobin, which was exactly after that sudden increase in the CO2 and or the blood pressure. But we found that in most of the cases, it was actually CO2. So playing with the mechanical ventilation or weaning too much or doing a lot of changes during the transition is not really preferred in very premature babies because that might induce IVH. In other group with absent IVH, absent severe IVH, I'm talking about grade 3 and the higher IVH, the blood pressure was almost linear, increased gradually as per normative data, and the CO2, there is no significant fluctuation in the CO2, and the cerebral blood flow was gradually increases without sudden increase secondary to any changes in the CO2 or blood pressure. And the hemoglobin was okay, just slightly increased because of blood sampling probably. So based on that, we realized that it is very important to know the normative blood values in preterm infant during postnatal transition. That's the most critical period. And the blood pressure usually plateau after that. So after that's not a problem, but during this transition, it is very important to understand it was not really easy study, and I will tell you why, because how we define the inclusion criteria, it is not really easy to define normal values for premature infant, because premature infant to start with is not normal. The infant born very early, and there's a lot of issues might happen during the transition. So to get a sample, we investigated 5 years among close to 600 infants, and we only got 200 with normative value. And you will understand that if I go over the inclusion criteria, which is we excluded inborn error, inborn infant born at outside the tertiary center. So only infant born and stabilized within the tertiary center did not receive any transfusion or volume expanders during the first 72 hours of life. Most of them, unfortunately, they receive. Hemodynamically stable, did not receive any cardiovascular support during that period. Stable oxygenation and the FiO2 did not exceed 50%, either invasive or non-invasive ventilation, did not receive nitric oxide, not treated for hemodynamically significant PDA during the first 3 days of life, no significant IVH grade 3 or periventricular hemorrhage, no early confirmed sepsis. So it is really extensive and also for sure survived until the time of discharge. So you can understand now why it was really difficult for other centers to conduct a research on normative value in premature infant. It was really difficult and tough. And I dedicated one investigator assigned to this program collecting blood pressure and other variables daily. So only his work is to collect data every day, full-time work for 5 years. So over that period, we succeeded and we collected the data. And as you can see here, for the first 72 hours of life, there's a normative blood pressure values for infant. For example, I took example for 23-week or preterm infant, and all of them, you will see the diastolic mean blood pressure and systolic blood pressure values increases gradually hour by hour up to 75 hours of life, and then plateau after that. And also in all of premature infants, started from 23-weeker up to 28-weeker, you can see the blood pressure gradually increases with increasing gestation age linearly. So we have now the normative trend, and simply we can define now what is the abnormal value if any infant behaving was outside these normative values. You have to be concerned about hemodynamic instability. So we extracted the table, which is available, published in the article, which is now easy to follow. If you have the infant lives in 5th centile and the trending down, then you have to take it seriously. And if you started medication and you now reach the blood pressure to 25th centile, then you can consider weaning or discontinuation of the medication. So that's really easy job to do now. And again, the most two important variables, diastolic blood pressure and the pulse pressure, which is the systolic minus diastolic. Now, we are on our track to define the shock. So we know, if we know normal, now it is easy to understand what's abnormal, what's shock. We cannot do it the other way around. We cannot assume definition of shock or hypotensive shock without understanding what is the normative value. So the definition of hypotensive shock or cardiovascular compromise, at least one of the following. Number one, low one or more of the blood pressure values below 5th centile with decreasing trend. Significantly decreasing trend more than 20% below the baseline. Number three, borderline blood pressure parameters. As I mentioned before, the most two important variable, the independent variable diastolic blood pressure and pulse pressure associated with oliguria or lactic acidosis. If you have borderline blood pressure, but we have oliguria or lactic acidosis not explained by anything else, then you have to treat it. Or low blood pressure with decreasing trend of the cerebral oxygen saturation if you are using near-field spectroscopy to monitor the cerebral blood flow. Now we'll come to another question. What are the reference ranges of the basic hemodynamic values beyond the blood pressure? Again, blood pressure is one of the parameters that we are relying on. But if you integrate to other parameters, which we call it in our unit, the integrated hemodynamics, then you will get much better view about hemodynamics. And we published that in this article, Integrated Evaluation of Hemodynamics, a novel approach for the assessment of management of preterm infant with compromised circulation. And as you can see here, we have other names from expert in hemodynamics in North America. And we published the centile values for the perfusion index, cardiac output, fraction shortening, systemic vascular resistance. As I mentioned, it's very easy to calculate if you have cardiac output. And then the cerebral oxygen saturation based on near-field spectroscopy and the fraction of oxygen extraction. And now I have this card or kind of memory card that you can keep in mind to remind you about the three types of shock: the vasodilatory shock, vasoconstrictive shock, and cardiogenic shock. So if you have this trend, the blood pressure trend, as you can see here, decreasing with maintained pulse pressure, systolic, diastolic mean they are decreasing below the centile value in this term infant. This vasodilatory shock, we are using norepinephrine or vasopressin plus minus fluids if indicated. We are not using dopamine in our unit for many years. Dopamine is a medication that might increase the pulmonary vascular resistance, reduce cardiac consumption of oxygen, and also might affect the oxygen consumption and the brain. So it is harsh non-specific medication with a lot of side effects. But if you're dealing with vasodilatory shock, you can use a medication that's more specific. The same even in PICU and adult, they are not using dopamine anymore. So you have the vasodilatory shock, low diastolic and systolic with normal blood pulse pressure, and this typical pattern of vasodilatory shock. You have the second pattern with the vasoconstrictor shock with normal diastolic or even increased above normal diastolic and narrow pulse pressure and pattern. This pattern can be treated with dobutamine or merinone, and merinone mainly if you have RV dysfunction. And then when you have everything is low and compromised, that's cardiogenic advanced shock. And as I mentioned before, you can use epinephrine as a preferred medication for that. You can also use this app, which is artificial intelligence app. It's called the Clinical Decision Support System for neonatal hemodynamics. It's available on App Store. And you can use it for blood pressure centile values, and also integrated with echocardiography. It can help you to calculate systemic vascular resistance and help you for weaning also the vasopressors, if you are not really sure to wean or not. So you have the first page, the centile values. You have to select the gestation age and age in hours. And if the infant's term is the infant on cooling or not as HIE, because that will affect the numbers. And you have to enter the number, and the calculator will let you know the centile values. And if you reach the 25 centile value, then you can consider weaning of the medication. These medications are very dangerous, and you should wean as soon as the infant stabilized. And then it is integrated evaluation of hemodynamics with cardiac output. If you enter the cardiac output values, the calculator will calculate for you the systemic vascular resistance And also, if you enter other echo, these are just very basic echo parameters. You don't have to be super expert in echocardiography, you just trained in neonatal hemodynamics, and you can get very good insight about what's going on. If you enter also the near-field spectroscopy value, you will get an idea about oxygen delivery and oxygen extraction. So it is full physiologic assessment of everything and can give you impression about what type of shock, vasodilatory, and what are the other causes that might be contributing and the intervention. And now, what's the impact of relying on physiologic trends? Someone might ask me, okay, so now we have been following very simple way of assessment, which is blood pressure equal to gestational age for so many years. So what's the impact of following this kind of more detailed physiologic trend? So simply, I can answer that we did that in our unit after we started the integrated hemodynamics assessment of using the detailed blood pressure values with the table available at the bedside nurse, looking at these centile values every day or every shift to be sure that the infant, as part of the vital sign assessment for every infant admitted to NICU, and then integrate that to echocardiography and near-field spectroscopy. So we did that for 3 years as Epoch 2 and compared to Epoch 1, which is before implementing this integrated hemodynamics assessment. And we did that for shock, for pulmonary hypertension, for PDA assessment. So for PDA, we reduced the PDA ligation almost to 0, and pulmonary hypertension significantly, we reduced the infants that are failing responsiveness to inhaled nitric oxide or sildenafil or pulmonary vasodilators. And here I'm showing you the impact on shock. So we have 340 infant assessed for shock over almost 5 years period. So Epoch 1, before integrated evaluation of hemodynamics, the time to clinical recovery was almost 71 hours to get the infant stabilized. This time was almost half time to clinical recovery in Epoch 2 after implementation of integrated hemodynamics. It means that half of the time for the infant to be stabilized, more stable, for sure that will impact the brain development, and half of the time the infant exposed to these kind of dangerous medications, and for sure also this will impact the neurodevelopment. You have much less number of deaths, but the study was not powered enough to evaluate mortality, but the trend of death is much lower. So now at the end of this presentation, I would like to remind you about a few things. The two important independent variable for the blood pressure is the systolic blood pressure and pulse pressure. And then the systolic and the mean blood pressure are dependent calculated variables. So they are very important and more important during weaning. So if you started the medication, norepinephrine or dobutamine for some time, and the infant now is stable, if the infant is stable, you can rely on one parameter like mean blood pressure, because now the infant is stable, so you can look at the mean blood pressure centile value, and you can wean based on that. But if you look at everything, that would be for sure better. Follow the centile values of blood pressure and other hemodynamic parameters. So look at everything that try to integrate as much as you can information when you treat for hemodynamic instability. The blood pressure trend is the most important reliable hemodynamic variable. The trend is the most important variable, which is again more than 20% for more than 30 minutes. Keep this number in your mind. If you have more than 20% below the baseline for more than half an hour, this is important to consider for management. Trend can be assessed as a graph trend or histogram. Don't just look at the blood pressure interrupted as interrupted time or any random time. Look at the trend over time, and the trend can be detected as a graph trend or histograms if you have a histogram integrated on your monitor. Thank you very much, and I hope that we have enough time for questions.
So thank you so much, Professor Yasser. It's an excellent presentation and so informative because till date, we are only using mean blood pressure for as per the gestation age of the baby to assess their shock level. But it's eye-opening to listen to your talk, and they're so informative that even like in Indian setting, we are usually using non-invasive way of monitoring the blood pressure. So it's very important to use the trains of the blood pressure to monitor them. And with the trains, we can de-escalate our therapies. We can change our inotropes requirement. And your calculator must be very, very useful. I hope that we all use this calculator to save our sick preterm neonates. So over to questions. I'll ask you.
Sure.
So the liver, yeah. She says that it's an excellent presentation, but she want to know whether the perfusion index is also related to mean arterial pressure.
Yeah, that's a very good question. So the perfusion index, which is a number available on the pulse oximetry, and I'm not sure why the company they made the number really small, so it is usually overlooked, or the people they usually ignore it. But it is very important to look at it for many reasons. First, the oxygen saturation is perfusion dependent. So when you have the perfusion index less than a certain number, which is 0.4 as defined by the company and by research, we should not rely on the oxygen saturation. So it means that the perfusion is poor and the number that you can see as pulse oximeter is not reliable. So it is between 0.4 to 2.2, we'll simplify it to 3. If you have more than 3, that might be a marker of hyperperfusion or hyperdynamic circulation. It might be detected in PDA, for example, or in vasodilatory shock. When you have the number low, or more important, trend low, it is also the trend. Keep the trend in your mind for everything. It's not just below 0.4 is abnormal or more than 3 is abnormal. The trend, if the infant was 2.2 and now is 0.4, which is still normal, this is abnormal because that's a significant drop in the trend. So it is signifying the peripheral perfusion. It is not related to central perfusion. So we have to keep that in mind. The central perfusion, you need to get the blood pressure. So the perfusion index is a marker to detect the peripheral perfusion. So it does not really, you should not reuse the perfusion index, for example, as a replacement of the blood pressure, because the blood pressure, that's for central circulation.
Oh.
So you can use both to let you know an idea about the relationship between the central perfusion reflected on the blood pressure and the peripheral perfusion reflected on perfusion index. For example, in HIE on cooling, you will see the trend of the perfusion index is getting low because the peripheral perfusion expected to be low and with cooling, but you see that you have to correlate that with the blood pressure because that's very important. The central perfusion, for example, for sure is more important. So it is helpful as a reflective of peripheral perfusion expected to be low in vasoconstrictor shock, in cooling, or infant with hypothermia, or infant of overall poor circulation, because you may have central perfusion low and also peripheral low as well, low blood pressure and low peripheral perfusion. So the most important to follow the trend and correlate that with the central perfusion reflected on the blood pressure.
Thank you so much. I think it's very clear now. So Dr. Anil Kumar is asking that from what BP centile onwards, we should start tapering inotropes if acceptable urine output and lactate. How many hours should BP should be stable before start tapering?
Yeah, that's another very good question. Okay, so usually once you start the vasopressor or inotropes for some time, it takes about 6 to 8 hours, usually in most of the cases, to get the infant stabilized. So I can't assume that you started norepinephrine and 1 or 2 hours later you stop it. That's not really practical and not the case. We don't do that in our practice. Usually 6 to 8 hours to get the infant stabilized between the 25th centile and 5th centile of the values. So don't wean if the blood pressure is still below the 25th centile, because that's just borderline and just stabilized with the effect of the vasopressor that you are using. You have to get the blood pressure at least at the 25th centile and the plateau is stable for 6 to 8 hours minimum. And then you can consider weaning as long as you have normal other parameters. Again, you have to look at the perfusion, urine output, improved lactic acidosis, and also if the infant, if you're treating cardiogenic shock or impaired myocardial performance, you can repeat the echocardiography and assess the cardiac output as well. Unless you are treating vasodilatory shock. Vasodilatory shock, you don't have to do echo because a normal pulse pressure reflects normal heart performance. I'm talking about vasoconstrictor physiology or impaired myocardial performance or cardiogenic shock. Echo is important, but vasodilatory shock, you don't have to wait for echo or confirm that by echo. It is typically vasoplegia. It is peripheral circulation, and the heart should be intact and working well.
So there are many complimentary remarks for you that it's a very excellent talk. Then,
Thank you.
And Dr. Bharat is asking that what is the role of hydrocortisone in the management of early hypotension in preterm neonates?
Yeah, that's another important question. You know, in the future, if we have a chance, we may dedicate a separate presentation talking about the physiologic management of shock, because I did not talk about that in details. I just focus mainly on the normative values and the assessment of blood pressure. But typically, if you started one medication and you are reaching the medium dose of that medication, then you have to investigate. Usually we send random cortisol level. If you don't have that ability, you can just give 2 milligram per kg of hydrocortisone. And if you see a response to that, it is an indicator that this infant is considered as suprarenal dysfunction might be contributing to shock. So you have to continue with maintenance 0.5 milligram per kg Q6 hours and keep it until you wean the vasopressor. So don't wean it first, wean it at the end. So we usually investigate for any infant who is requiring, for example, if you start 0.05 of norepinephrine and now you escalated the dose and you are at 0.15, maximum dose is 0.3. So it is a medium dose between the lowest and the high dose. If you reach that dose and still the blood pressure an issue, investigate for suprarenal dysfunction, either by giving this dose of hydrocortisone or send a random cortisol level, and also you can give until you get the level back. And keep in mind that random is random. You can get very high number, but if you test it in another few hours, you may get it lower. So don't assume that the random is fixed for days or long time. It just give you a rough idea about the response of the suprarenal gland to the stress. So I advocate to use it if you are escalating the dose and there is no good response, as long as you are using the right medication, right vasopressor, I mean.
Yeah, I think that's very important because if you are not using proper vasopressor or if you start using hydrocortisone, that it might create more problem to the baby, especially for the neurodevelopmental outcome. So we should be a little cautious, I think, when you are using the hydrocortisone. Yeah, that's very nice. So the next is Dr. Jagdish Sahu. So, sir, can you please describe the memory card that you explained? What should be the target blood pressure when we should start weaning?
Yes, probably I mentioned that, but just repeat again. If you reach the 25th centile of the value in the table, you can use a calculator. The calculator will help you. And we have that on our website, neobeats.academy, because it's only App Store. If you don't have Apple phone, you may not be able to use it, but you can use it on our website. It's also available on neobeats.academy website, and you can use it from any computer or any cell phone. If you reach 25 centile value, then you have to consider weaning as long as other parameters are fine, like passing urine, normalized lactic acidosis, and also no significant acidosis overall, because you have to get at least a pH more than 7.2 to get a good response of weaning. If the infant is still acidotic, it means that the might not respond well to weaning or might not respond at all to the catecholamines. In this situation, just to mention that in severe acidosis less than 7.2 pH, and if you have significant issue to maintain the blood pressure or norepinephrine, we are using vasopressin, because vasopressin might work on with low pH. So if you have issue with getting the catecholamines, maintaining the normal blood pressure, you can use vasopressin if you have it, or terlipressin, whatever generic name you have for vasopressin, you can use that, and keep in mind that should not be used if the sodium is low, less than 130. And vasopressin used only in one line. So you should have a central line like double lumen, and should be by a separate line because it's not compatible with other medications.
Okay. That's very important. That's very informative also. So
Yeah.
next question is from Tarek. So for hypotension in babies with congenital diaphragmatic hernia, what will be your approach?
Well, sorry?
In babies with congenital diaphragmatic hernia, what will be your approach if the baby is having hypotension?
Yes, that's a very important question. Again, I have a separate presentation on cardiovascular support or in congenital diaphragmatic hernia. So you need a dedicated presentation for that, because it's not as simple as low blood pressure. You have also pulmonary hypertension, which might be resistant to pulmonary vasodilators. You may have combined systemic hypotension with pulmonary hypertension. And this situation is based on the echocardiography, because we should do echocardiography to rule out significant pulmonary hypertension. If there is LV dysfunction, we use milrinone or dobutamine in this situation. If the blood pressure is low, because milrinone might lower the blood pressure, we add norepinephrine. So sometimes we are using mix between milrinone or dobutamine and norepinephrine if the blood pressure is low. If there is LV dysfunction or RV dysfunction, but with normal blood pressure, systemic blood pressure, we use only milrinone or dobutamine plus inhaled nitric oxide for sure, or sildenafil if you don't have nitric oxide. So it is based on the type of shock. Simply go back to the is it vasodilatory? You can use only norepinephrine or vasopressin. We prefer to use vasopressin because if there is element of pulmonary hypertension, vasopressin also will help in pulmonary hypertension. If you don't have, norepinephrine is also a useful medication with high pulmonary vascular resistance, but don't use dopamine. That's the bottom line. Don't use dopamine in the diaphragmatic hernia because that might induce or increase pulmonary vascular resistance. If you have any ventricular dysfunction, then use dobutamine or milrinone, either alone or with added norepinephrine if you have associated with that systemic hypotension. And fluids for sure if you have underfilling of the heart or any impression of hypovolemia. Keep in mind the volume. It's very important to be sure that the tank is full before using the cardiovascular medications.
I think so. That's a very important message, that not to start dobutamine in cases because they might increase the pulmonary vascular resistance.
Exactly.
So I think, so that's very important. So now we'll go to the next question. That is Dr. Muhammad asking that how to follow the BP trends in NICU, and is there a special monitor to check the trend of blood pressure in NICU? Thanks.
Sorry, how to follow the
BP trend in NICU, and is there any special monitor to check for the trends?
Yeah, so the blood pressure trends, there's two types, either invasive blood pressure and invasive for premature infant or infant who just born. We are using umbilical arterial line. And if the infant's sick and we cannot get umbilical line or infant beyond the postnatal transition, we are using radial line. Radial line for invasive blood pressure. I know that some units, they don't have the ability to monitor invasive blood pressure. It is like a big issue in a lot of middle income countries, because it is like you need one nurse dedicated at the bedside, and you need a good monitoring, you need good antiseptic measures. If you don't have the ability for invasive, which is just the blood pressure connected to the monitor, and the monitor, the cardiorespiratory monitor should be able to detect that. You don't need a special monitor for that. If you don't have the ability to monitor the blood pressure invasively, then you can apply the cuff method. And because it is not really accurate, 100% accurate, do it as a trend. So apply the cuff, and you can adjust the monitor to measure it, like will be automated measurement every 10 to 15 minutes. You don't have to do that manually every 10 minutes. That's too much labor time. Just adjust the monitor, and the monitor will make it every 10 to 15 minutes and get the trend. Only we are doing that frequent measurement of non-invasive pressure if the infant's unstable. If the infant is stable, you measure just once a shift or once every 4 to 6 hours is enough, because that's really painful to apply a cuff and make it inflating the hand every 10 to 15 minutes. Only if the infant is unstable and you're wondering to start cardiovascular medication. And then over time, you'll see interrupted blood pressure values and get just imaginary line on top for the systolic and the bottom for the diastolic, and you can see the trend. If the trend is consistent with vasodilatory or vasoconstrictor or very narrow pulse pressure as a cardiogenic shock when you have everything low. So you can get an idea about the medication that you have to use. Should you go ahead and use epinephrine, the cardiogenic, or if it is consistent vasodilatory, you just use more epinephrine or vasopressor. If you don't have invasive blood pressure, if you have the ability to monitor the brain cerebral oxygen saturation by NIRS, that's another way to get an idea about the autoregulation. We are using near-field spectroscopy as a routine for 5 indications: premature infant less than 72 hours of life, less than 28 weeks, in HIE, in infant with developing hydrocephalus, infant with high oxygen requirement, and infant with hemodynamic instability. So these are the 5 indications. We are not using for everyone. We are using only for these 5 indications, and will give us added information about the cerebral blood flow and the fluctuation of the blood pressure impact on the cerebral blood flow.
So I just have a query, which you said that we need, though it's good to see the check for the trends, but if the baby is sick and we feel clinically that baby is in shock, so the baby's peripheral pulses are poor or steady and the CFT is prolonged, because most of the time we use clinical parameters also. So then it's very difficult to check for how much time we should look for the trends before starting the inotropes or vasopressors.
Yeah, if you had the trend, decrease the trend, not for very long, like 30 minutes. If you see the blood pressure trending down, and again, you don't have to wait until you get the blood pressure below normal value or below the percentile. If you see the baseline, blood pressure was, as the baseline, for example, 50 milliliter mercury, and then dropped to 40 or 35, which could be still above the percentile, but that's a significant drop of the trend, then you should consider treatment. That's 20% drop for more than 30 minutes. So you don't have to wait until you get the infant totally compromised. So that's significant. 30 minutes is enough to see significant trending for more than 20%. We apply that for the blood pressure and also for near-field spectroscopy. If you are lying on, you said maybe perfusion, but maybe you meant the capillary refill time, which is not very sensitive, to assess the perfusion, because again, that's just the perfusion, preferred perfusion. It's the same like perfusion index. Blood pressure is more central. Like there is no any substitute parameter to assess the central perfusion other than the blood pressure, plus minus the cerebral perfusion by NIRS, plus minus echo if indicated.
Thank you so much. So I request now my co-moderator to further carry this session forward.
Yeah, but again, if we need to talk more about the shock and management of shock and the trends of treating shock and weaning medications, you need another dedicated presentation for that.
So Dr. Karthik, can you please carry it forward?
Thank you, Dr. Mamta. Thank you, Professor Yased. Your lecture was very concise, and I especially liked the single slide in which you had all the physiology problem and which inotrope to give. It was a beautifully summarized slide. To carry on with the questions, a lot of participants today and many questions also. Dr. Khalid wants to ask, when do you start inotropes? I would assume that he means which are the BP cutoff or what are the what are the clinical findings on which you would start inotropes?
Yeah. So that's again a question might need a separate presentation on shock, but I will summarize. And as you mentioned, typically in the slide, the memory slide, which summarizes which inotrope can be considered for which type of phenotype of abnormal blood pressure. And we divide that into three main phenotypes. So again, the inotropes is many categories. This is not just one category. We are talking about this category of vasopressors. And vasopressor, either norepinephrine or vasopressin, this is dedicated for vasodilatory shock. Not all of them are the same. If we are talking about, there is a category which is mixed between vasopressor and inotrope, which is dopamine and epinephrine. Both medication can work as vasopressor and inotropic at the same time. We are not using dopamine for many reasons, as I mentioned, and we are using instead epinephrine if you have issue with both vasoplegia or vasodilatory shock, and also the heart is not contracting well, which is late cardiogenic shock. And then the third category, which is inotrope with vasodilatory action, which is dobutamine or merinone. Merinone is a medication with significant vasodilatory action. We are actually using this medication guided by echo because it's long half-life. The half-life is around 4 to 6 hours. And if you start the medication and you want to stop it, you will get still low blood pressure for many hours. So we are using this medication guided by someone expert in echo, either hemodynamic expert or cardiologist. And you can use instead dobutamine, which might give you the same action or almost the same. The extra effect of merinone, it is lusotropic, which expected to improve the diastolic relaxation of the heart as well. So you have to select the medication based on the type of shock. So if you have the blood pressure drop below the 5th centile with normal pulse pressure, just to make it easy and simple, you have the blood pressure dropped, but pulse pressure is normal, then use vasopressor. So I can tell you that 80% of the cases that require medication to support blood pressure, they require vasopressor, not inotrope. I mean vasopressin or norepinephrine, 80% based on our data that partially published before and we're still publishing, 80% of them, and or even 80 plus. Less than 20% of cases, you may need to do an echocardiography because of expected impaired myocardial performance or vasoconstrictor shock. Then you have to select either between epinephrine or dobutamine. In this case, you will see narrow pulse pressure, or all of the blood pressure parameters are low, including narrow pulse pressure. If you are not sure, epinephrine might be a medication to cover everything. If you see that the diastolic blood pressure is not very low, then you can use dobutamine. Because once you escalate dobutamine, you might get the blood pressure dropped. So it's better to start the dobutamine when you have the diastolic blood pressure at least not very low. So again, look at the table. The tables already published, already online, and I think I have in a lot of websites. If you just Google the table, you'll get them. And the app is available. You have all of these centile values available on our website, neobeats.academy. Just enter the blood pressure, and the table, the system or the artificial intelligence will let you know if the blood pressure below the centile values or not. That's an easy way. And again, as I mentioned, there is very simple to select the medication. Keep in mind the category is vasopressor versus inotrope. Vasopressor, when you have normal pulse pressure, that's 80% of the cases. Inotrope, when you have normal pulse pressure or cardiogenic shock or confirmed impaired myocardial performance by echo.
Thank you, doctor. The next question is Dr. Atul Lunde, who wants to know, does the value of pulsatility index depend on the make of the multipara monitor? It is, does the brand of the monitor make a difference?
The type of the monitor, the brand, you mean?
The company, yeah.
Yeah. Like I don't have to mention companies by name, but I think there is very well-known 2 or 3 companies that they are very dedicated in pulse oximetry. And usually it is integrated with pulse oximetry. So that if you are using a separate pulse oximetry machine, it should be on that machine, or you may have it pulse oximetry integrated with a cardiorespiratory monitor like in our unit. So there is 2 or 3 companies, they are very well known, like to use the pulse oximetry, and you can actually go to the one of the auction trials. So you have the Canadian auction trial and the other support trial or other trials. You use the machine. So these are the machines that are really reliable. I don't have, like, because of conflict, I should not mention the machine by brand. But all of like these machines like used in these trials are really reliable to be used as pulse oximetry, and for sure they are also reliable to use as perfusion index. And I think you meant perfusion index.
Yes, sorry, perfusion index. The next question is from Dr. Bharat Vakaria. He says to thank you for sharing your views on pulse pressures and diastolic BP. Now, if the baby is passing good volume of urine and has a normal CRT, should we still bother to consider antihypotensive measures?
Yeah, that's a wonderful question. Again, that's very important to integrate between multiple variables. One blood pressure parameter separated doesn't mean anything. It could be low, and that could be acceptable for that infant. So if you have because a number also might be subjected to artifacts or error in measurement, especially if you are using cuff measurement. That's why you need to do a trend over time, and you need to do from multiple sides. You may need to do from the outer limb or lower limb and compare. You may need to do 4 limbs. If you have arterial line, that might be perfect and the most reliable. Even the arterial line, you may have also technical issues. If the line is partially blocked or you don't have good waves, that's why blood pressure alone, if you have everything else normal, including perfusion, urine output, and blood gases, no acidosis, so that most probably there's actually technical error in the measuring the blood pressure. Yeah, sorry, I think you're muted.
Sir, you are muted.
The next question is from Dr. Bharat Srivastav. He asking whether the most common underlying reason for wide pulse pressure in early neonatal period is a wide open PDA rather than vasodilatory shock. So he wants to know, is this true or false?
Yes. Okay. Yeah, that's very good question. So they are totally different. If I'm talking about vasodilatory shock, usually the pulse pressure is not wide. It is normal or slightly wide because you may have hyperdynamic circulation. But you will see that the trend over time. So you see the trend is decreasing and the pulse pressure is almost the same. In PDA, because the PDA is not open in just 1 minute, it's open for some time, you will see the wide pulse pressure, but the plateau is, the blood pressure is plateau, is not really trending down significantly. And you will see that the systolic blood pressure is expected to be low in significant PDA, but wide pulse pressure with normal systolic pressure. In case of vasodilatory shock, you see systolic and diastolic both are low, but with maintained pulse pressure. So that's the main difference. So there's 2 main differences. The trend is decreasing significantly over a short period of time in vasodilatory shock, and the pulse pressure is normal or slightly above normal with low systolic blood pressure. In PDA, you have high systolic and really like wide, that is really wide, and it is plateau, not trending down. And for sure, you have to investigate the PDA is confirmed by echo, and the infant not behaving like septic. So there is no explanation to be vasodilatory unless you have, in rare situation, septic shock associated with PDA, because the sepsis might reopen the duct. That's another thing that to keep in mind. So you may have both conditions at the same time, which we call it overlap physiology. So there is another type of physiology. I mentioned only 3 types. There is the shunt physiology, and there is hypovolemia physiology. I mentioned only 3 times because, as I mentioned, you need a dedicated separate presentation to discuss the entire phenotypes, all of the phenotypes of shock, including the shunt physiology and hypovolemia and restrictive physiology. There is so many other types. In shunt physiology, you may have also septic shock on top of that, because the PDA might reopen because of the septic shock. And that will be based on the clinical circumstances and also confirmation by echo.
Dr. Vikas Agarwal, thanks you for the wonderful presentation. He asks, are the BP values mentioned in your presentation based on non-invasive BP, that is cuff BP? Or in that case, how does that correlate with the arterial BP? Your presentation is based on invasive or non-invasive?
Yeah, so, my presentation overall, I mentioned both. But the study that we did in our unit during the postnatal transition on normative value based on invasive only. So only invasive blood pressure, we excluded any infant without arterial line inserted, umbilical line. But there is another study that I recommend to follow, and we extracted some tables also available on our website, which is a Zobro, a study that was done in California, 1996. I have that in one of the slides. And I showed the table that we are using and including the pulse pressure. So that study was based on non-invasive. So regardless, it's no problem. If you are relying on non-invasive, you can use the Zobrotic study, which we have the tables available also on our unit, and we are using that until the corrected age of term. So they started from preterm 23-weeker every week until corrected age of term. Or if you have invasive method, you can rely on our study, published study. So, and I showed both in ours in the presentation. But my study and normative data that published in pediatric research was based on invasive blood pressure.
Dr. Khalid has a question. How do you titrate inotropes? So when we're saying inotropes, I mean inotropes or vasopressors. How to titrate these drugs? Can you do it? Should you do it slowly, or can you stop abruptly once a BP is maintained?
Very good question. This also might need a separate presentation, which is titled as the titration of cardiovascular medication. Unfortunately, there is not a lot of publications talking about the titration there, considering when to start and what medication to start. But they did not talk about the appropriate titration, which is also very important to know. So it is based on the half-life of the medication. So if you are using catecholamines, the half-life is very short, few minutes. So you can titrate quickly, and how quickly it's guided by the blood pressure. So we can titrate every 15 to 60 minutes by 1 to 2 vasoactive inotropic score, which means that if you are using dobutamine, so it is titration by 1 to 2 mics per kg per minute every 15 to 60 minutes based on the blood pressure. So you decrease by one step and look at the blood pressure maintained for 15 to 20, 60 minutes, and then wean again. Like 15 minutes, if you have the blood pressure normalized very quickly and the infant stabilized. If the infant took long time to be stabilized, you need more time to wait to be sure that the blood pressure maintained. And for the vitamin per se, I usually consider at least 30 minutes to 1 hour, and norepinephrine 15 minutes might be enough. Because the half-life, again, is talking about 2 to 5 minutes half-life. So once you drop the medication, you should see the effect quickly. And do that guided by the blood pressure. As long as the blood pressure, just like that in the chart to the bedside nurse, that wean the blood pressure every 15 minutes. You can make it if the infant is not very stable, up to 1 hour is not a problem. If the blood pressure above that value, and consider the value is the 25th centile for the gestational age as a cut limit value. If the blood pressure maintained above that value, continue weaning. If you are using Merinone, it is long half-life. Then you have to wean slower. So we are talking about 4 to 6 hours interval. So we usually start at 0.3 maximum up to 0.9 mics per kg per minute of Merinone. Wean by 0.1 to 0.2 maximum every 4 to 6 hours. And that because of the half-life is long. If you are using vasopressin, the half-life is around 1 hour. So wean it every 2 hours. Wean by, if you are using milliunit, we are starting at 0.3 milliunit per kg per minute. then you can wean by 0.1 millionate every 2 hours, as long as the blood pressure maintained. And if you are using hydrocortisone on top of that, keep the hydrocortisone the last medication to wean, and wean it on daily basis. So for example, if the infant is getting the hydrocortisone Q 6 hours, wean one day Q 8 hours, and keep it until next day. Wean it every to be Q 12, and the next day to be off. So wean it on daily basis, not very quickly, because the hydrocortisone has longer half-life, and a lot of premature babies, they have impaired suprarenal function. So you need to monitor that, and they might need to be in hydrocortisone for longer period of time.
The next question is by Dr. Vikas Agarwal. If you start dobutamine for preterm babies with shock, how do you titrate the dose, as the dobutamine improves organ function, but the effect on BP itself may be not directly correlated with the improvement in organ perfusion?
Okay, wonderful. Very good question. So we are using dobutamine if you have at least normal or close to normal diastolic blood pressure. Don't use dopamine when you have very low diastolic blood pressure. Otherwise, as you said, the blood pressure might drop even further. Otherwise, you use epinephrine, not dobutamine. So if you have low diastolic blood pressure with normal pulse pressure and low systolic, use epinephrine instead. If you have almost close to normal diastolic, but normal pulse pressure and low systolic, then use dobutamine. And if you are increasing and then later on the blood pressure dropped, no problem. You can add norepinephrine, the second medication, or you can replace the dobutamine with epinephrine. That's another option. Once you get the blood pressure stabilized for 6 to 8 hours, then you can start weaning. And again, how frequent you can wean, as I mentioned, in dobutamine, I wean every 30 minutes to 1 hour by 1 mic per kg per minute. So with the infant on 10 mics, wean from 10 to 9 and then 8. Once you reach 5 mics, then you can wean completely. You can discontinue, I mean.
The next question again by Dr. Bharat Wakaria. How well does intra-arterial continuous BP correlate with blood pressure BP?
Yeah, it is based on the if you are using the perfect method, the right size of the cuff, covering 2/3 of the arm, and not very tight and not very loose, it is already the perfect. It is in literature correlating mainly with the diastolic and mean blood pressure more than systolic and pulse pressure. So the systolic and pulse pressure is more accurate on the invasive, but in diastolic and mean, you may get that almost comparable to the invasive if you are using the right technique and the right size of the cuff. And again, you have to measure it multiple times. So at least 3 times, 3 measurements. Don't just rely on 1 measurement. 3 measurements at least or more if you continue every 15 minutes if the infant is unstable.
I think next few questions are repetitions because Dr. Manaf says that what does NIBP correlate with the clinical parameters, which you have already answered, CRT and other things. Then how to wean inotropes already you said. So now Jaya P is asking, she said it's an excellent talk. And what are the recommended starting dose for various inotropes? I think that also you have answered. So does severity of shock plays a role in deciding the same? When should we add vasopressin to the management? So I think it's a separate talk you required for the inotropes and the vasopressors, and so many queries are coming. Dr. Manoj want to say something?
Sorry to interrupt, Dr. Mabda. I just wanted to ask Professor Yased, it's such an amazing talk and elaborate discussion. Do you have more time? All the time that you have mentioned you will spend with us, all the time is over. Do we have another 5 more minutes to wind up?
No problem, it was pleasure. That's fine.
Thank you. Please go ahead, Dr. Mamta.
Okay, thank you, sir. Thank you. So the Bharat again is asking that do you suggest adding a new drug to manage hypertension, or do you change to a new one and discontinue the previous if the response is not seen in 30 to 45 minutes?
Okay, that's very good question. Wonderful question. Because one of the main issues, again, if you have in the future a chance to discuss the shock in more details, one of the main issues that we may encounter when you add medications over medication, you may get more side effects, not improvement. Especially if you add so many inotropes to high dose, you may get impaired myocardial relaxation or diastolic functions. So when you use inotropes might improve the systolic performance on expense of diastolic relaxation. So at the end, just to make it easy to imagine, if you give too much, for example, dopamine of 20, added of dobutamine of 20, epinephrine of 1. I have seen maybe one patient like that. When you assess by echo, the heart was empty and the heart was contracting like convulsing. So the heart is very stiff, does not relax. So the heart cannot relax to accept the venous return. Heart was very almost at one stage of systolic contraction and almost empty in systole, and the infant was almost dying. So what we did at that time, just we discontinued all of the inotropes, and the infant was and we gave fluids, and the infant improved. That's one of the cases that I remember for so many years now. I'm using the same case to teach the side effects of using so many inotropes with high dose. So if you start one medication and there is no improvement or worsening, it means that you are not in the right direction. So you can easily replace it. And if you are using catecholamines, the half-life is very short. If you stop it and use another medication, the interval is very short. The other medication will work within 5 minutes. If you are worried, you can give overlap of 15 minutes. That's not a problem. Start another medication and overlap 15 minutes and then stop the first one. But don't keep all of the medications and keep adding one over one. At the end, you will get the infant deteriorated, not because of shock, because of the impact of adding so dangerous medications. And again, don't worry, the medication is very short half-life. If you need to restart again, you can start and you'll get the effect within minutes. So 15 minutes overlap is enough. For example, if you started dobutamine and blood pressure dropped, and now you are thinking I should start on epinephrine because of the very low blood pressure, that's okay. Start on epinephrine, in 15 minutes, stop the dobutamine. And that as easy as that, but don't keep both medications. The only case that we keep two medications if we need really both medications. For example, if you have LV or RV dysfunction and we need merinone or dobutamine, but the infant developed low blood pressure because of merinone is high dose, which is still needed for RV dysfunction, we add norepinephrine to support the systolic systemic blood pressure. And to maintain the blood pressure at a reasonable level, then we add the medication for a reason, but not just adding medication because the other one is not working well, and we keep both.
Right, that's great. So I'll take few questions, few important, good, interesting. So is there any role of close monitoring of calcium and sodium in the management of hypertension?
Is there any role of what, sorry? The
Calcium and sodium in the management of hypertension. Is there any role, or how do you monitor them?
Yeah, that's very important question. So typically in sick infants, we monitor calcium, phosphorus, and sodium, potassium in daily basis. And easy to get that also in the blood gases. If in some units they have in the blood gases, at the same time you have the electrolytes and the hemoglobin. If you have this ability, that's wonderful. And again, it's very important because if you are using medication like vasopressin, it might induce hyponatremia. And you may need to get the sodium at least above 130 to get the hemodynamics improved. So it is very important to get the electrolytes, and more importantly, to get the pH at least above 7.2 if you are using catecholamines. In some situations, if we are unable to control acidosis and the catecholamines are not very effective, we are using vasopressin, which is not very pH dependent and very low blood pressure. But it's important maintain the pH above 7.2 Sodium at least above 130. For sure, potassium, calcium should be normalized.
Okay. So sildenafil and congenital diaphragmatic hernia, I think it's the separate the class you need for this, separate lecture you need. I think we'll go with some related questions as Khalid is Jennifer is asking that what is your view of getting cortisol level before starting steroids? So do you need to do the serum cortisol levels?
Yeah. So we do that as a routine. And if we are relying on 350, if the number is 350, for sure we'll continue. But there is a lot of limitations of that because it's random cortisol level. So it is really helpful if the number is low. If the number is low, it means that we have to continue with hydrocortisone. But we don't have to wait to give the loading dose until you get the results back.
Right.
So send the level, that we do that. Send the level, and then the level might come after 2 or 3 hours and give the hydrocortisone loading dose, which is not very harmful even if you give it with high cortisol level. If the level is high, this does not rule out suprarenal dysfunction because it could be high now, and if you test it 2 hours later, then it might be low. So sometimes even we'll continue with hydrocortisone when the cortisol level is a little bit high, when there is severe shock. But if the level is low, definitely, it is unlikely to be false negative or false low. But you may have false high results. So it is helpful when it is low, but we do it as a routine.
So another question by Dr. Lal is that can a normal saline bolus be the first option in a neonate with clinical shock? I think,
Yes.
of course, yeah, that's
If
true.
you are not sure, I will give you 2 categories. If the infant was not normal pulse pressure, and pure vasodilatory shock with no impression of third space losses, then you may give just vasopressor. But if the infant was narrow pulse pressure and you don't have echo, the narrow pulse pressure could be due to low stroke volume or underfilling of the heart. If you are not sure, at least before you start to do butamine or inotrope, prime the heart or the circulation with at least 10 cc per kg of normal saline bolus, because you are not sure. Only if you did an echocardiography and the echo showed very good filling of the heart, there is no issue with the volume, there is no third space losses, and you are not worried about the volume depletion, then it is not mandatory or part of the management plan. If you are not sure, you can give 10 to 20 cc, but don't keep giving the boluses without
Right.
understanding is it really helpful or not. And it's easy to watch the blood pressure. If you give the bolus and you see the blood pressure immediately improved, that means that the infant's responsive, volume responsive. It means that the infant's really volume depleted. Here you see the normal, the urine output improved.
So the Jaya P is asking, which is I think very relevant. Sometimes we feel that many times neonate become irritable and cry vigorously when the BP cuff inflates during non-invasive monitoring. How much error in BP measurement can we expect because of this?
Yeah, that's a very good question. So if the infant is really sick or unstable, sometimes you are using medication like we have to respect pain for neonates. So we're using morphine or fentanyl, either infusion or as PRN doses to settle the infant who's really in pain. We should not measure the blood pressure when the infant is like in pain or very irritable. And if you are considering an error issue with the non-invasive blood pressure, multiple measurements, at least 3 measurements, and follow the trend might give you an idea about if the initial measurement was really high because of irritation or so, or now normalized or false high. So respect the pain of the patient is really in pain, and don't measure the blood pressure when the infant is really agitated or not really relaxed well. And the multiple measurement over time is very important. And you can use different limbs, not only one limb.
Yes, thank you. So the next question is, what will you do in PDA physiology of hypotension? And is this indication to treat, especially with impaired urine output? And what you will do if the infant is 2 weeks old with PDA physiology of hypertension?
Yeah, that's a very good question. So usually the PDA in most of the premature babies, it is causing pulmonary overcirculation. And very small number of them, it might affect the systemic perfusion, especially beyond the postnatal transition period. So usually we see increased oxygen requirement, increased ventilatory support, but in rare situation, you may see low diastolic blood pressure with hypoperfusion of the systemic circulation and especially kidney. If you do echo by yourself, that's really helpful because you may also do the renal artery Doppler. So if you see the PDA is significant and you see there is reverse diastolic flow in the renal artery associated with decreased urine output, that's definitely related to the PDA. Then you should treat the PDA. Keep in mind that might be aggravated with two things. This PDA shunt physiology is expected to be aggravated in premature babies due to two things. Suprarenal dysfunction, which is in a lot of situations not really looked at properly, and if the infant is developing sepsis. So for example, if the infant was PDA for 2 weeks now, even if it's significant, not closed, but suddenly the urine output dropped. So why it is really dropped now? The infant has been stable for 2 weeks. So that's something wrong going on. The most two things to keep in mind, either developing a new sepsis or new inflammation or new neck, which might also increase the shunt through the PDA because of the dropped systemic vascular resistance, or it could be suprarenal dysfunction, which you may investigate by sending cortisol level. And a lot of cases, we have seen that failure of non-steroidal anti-inflammatory with big shunt, and the infant responded to steroids because of suprarenal dysfunction.
But in this case, if the baby is having sepsis, or because blood culture will take at least 24 to 48 hours to come, and if we give steroids, does it have some harmful effect on the baby?
Yeah,
This is
like
my
no,
query.
I'm talking about two different situations.
Yeah.
Either either infection might be contributing, which you for sure you have to send the blood cultures and
Right.
start antibiotics. Steroids only if suprarenal dysfunction, which might not be associated with infection, but if the septic shock associated, if the infection associated with septic shock, you may use hydrocortisone to treat shock, not to treat the PDA with assumed suprarenal dysfunction with infection. So that's two separate situations. Only if infection associated with septic shock and you already used norepinephrine or vasopressor and the blood pressure is still low, and now you're really worried about worsening of shock, so you need to add hydrocortisone. But if you already started on antibiotics, no problem. If you already started on antibiotics, already infant covered those antibiotics, broad spectrum antibiotics, that should be fine if you're already treating bad septic shock.
Okay. So the one last interesting question, because there are too many, but you have already answered them in between. So is blood pressure chart suitable for IUGR? IUGR
Yeah,
babies.
yeah, that's very interesting question. When we use the centile values, we did not actually correct for IUGR because the population is not very high. So that you need huge sample value to do that, and so many years. So like you can imagine we stayed 5 years to see the normalized value, and we excluded so many of them because of because either they are unstable or received medications or whatever. So that was very tough to exclude also IUGR or to correct for IUGR to get a centile values for them. You need really huge sample size. But what I can say that usually in IUGR, they may have very premature babies, they may have issue with heart performance during postnatal transition. For example, when you have the placenta with very high resistance and the heart is very premature, the infant born, we have seen that in few cases in very significant cardiogenic shock or vasoconstrictor physiology in second or third day of life. And you will see the pulse pressure narrow for them. We just follow the same normative value. You don't have to follow any specific, but the echocardiography should be very helpful to diagnose impaired myocardial performance for them. So just imagine that the heart was contracting against high resistance before birth for a long time, and the infant just born with that high resistance. Premature heart may not be able to keep contracting after birth against that high resistance and might fail in 1 to 2 days. Term babies, usually term IUGR babies, they compensate for that without any issue. So we see them issues, but that's not very common. We see every year maybe 2 or 3 cases preterm IUGR, and they may have severe postnatal cardiovascular compromised cardiovascular circulation. And it is very clear on echo, you see the heart performance very poor. And you need to start dobutamine or Marinol for them.
I think it's an excellent talk with excellent discussion, Professor Yased. And I feel that we should have much more time for you, like really want to interact you much more before. So I hope Dr. Manoj will again call you for the next session.
That calls for another session, and
Yes.
probably, because I mean, we are truly today enjoying the fruits of tiring, challenging research that has been carried out, and then he has made it so beautiful in a concise presentation. But I can imagine the kind of challenges that it must have posed, getting these. This is some venturing into a novel territory, even though we consider it as like something that we take it for granted. And so, like, definitely we would love to have you, Professor Yased, for more interactions in the coming days. We will definitely keep in touch with you.
Sure. Yeah, communicate with me at any time, even like outside formal presentations, with pleasure. And we have a lot of other platforms, and probably we'll share with you our webinars as well. So you can maybe share your announcement of your webinars and also share from ours in Canada. So a lot of future presentation might be focusing on related topics related to not only the blood pressure or hypotension or shock, related to management of sick infants in general, pulmonary hypertension, chronic lung disease, ventilation related issues. We have a lot of things on our platform, Neonates Academy, and probably I'll connect you with our team, and you can kindly share our future webinars. And we're looking forward to do more collaborations and more webinars in the future.
We will definitely love to do that, actually, because we believe the very fact that this whole series has been on the principle of knowledge sharing, free knowledge sharing. Knowledge is for sharing, and that is the thing. So we would definitely love to do that and interact with you in the course of future. Now, if it is okay with both the moderators, can we wind up the session, or like any more questions?
No, thank you so much.
I know there are a lot of questions I am seeing in the question answer person, but then we are so fortunate to have you have our faculty for so long. It's not advisable not to stick to time when we say time. So probably we'll wind up here. Before we close the session, we have the Secretary General of National Neonatology Forum India, Dr. Surendra Bisht. I would request him to speak a few words, then we will conclude. Over to you, Dr. Surendra.
Thank you, Manoj. And I'm so glad even in the last month and the last fag end of this year, we are able to do one more next webinar. And I'm really grateful to Manoj for having done so. On behalf of National Neonatology Forum, Professor Yased, I extend my gratitude and thanks to you for having conducted such a wonderful session. And the kind of, in fact, you rightly said, it was about blood pressure of babies, it was so difficult to measure because the inclusion criteria was so strict. Almost 9 or 10 inclusion criteria. I felt you would not get any preterm of that kind in any of the NICUs. That is why you just had one tertiary center measuring it for 5 years or so. And then also somebody is asking for IUGR was such a big questions for things. A great job there. And I think all the participants, we struggle with our inotrope vasopressin. That is what the questions were. We went from blood pressure and mean blood pressure to inotrope and vasopressin, but you have answered all. Thank you, Dr. Mamta and Karthik. And Manoj, that's a great. And we are looking forward for next year's next webinars with that kind of a spirit and enthusiasm. And we really want to take it some steps higher, obviously, certainly. Thank you.
Thank
Thank
you,
you,
everyone.
Surinder.
Thank you for wonderful moderations, and I really enjoyed every moment and all of the questions from everyone. It's a great pleasure, and I wish of the time can fit to answer all of the questions and enjoy all of the discussion. But in the future, hopefully we can have another maybe chance or another opportunity to go over more details about shock and how to manage sick neonates. Thank you, everyone.
Thank you, Dr. Yasser, once again. I would also like to thank the moderators for today, Dr. Mamta Jaju and Dr. Brigadier Karthik Ramohan for moderating the session so very well. And last but not the least, thank you, all the respected attendees who have been with us for the last now 3.5, nearing 4 years. Since June 2020. It is a huge journey of learning, unlearning and learning that we had in these days. So please do continue to join us in the next sessions as well. So this is, as we mentioned previously, this is the last session of this year. Next year, because of the National Congress of the Indian Academy of Pediatrics, we won't have a session in January. So in February, 1st of February, we will have the first session of 2024. That's on BPD. And then from then onwards, we will continue. So all the details will be shared to you individually. With these words, with all your permission, we will wind up for today. Thank you so much, everyone.
Thank you.
Thank you.
Thank you. My pleasure. Bye.
It's an honor.